Tracy Colmos to be our Grand Rounds speaker. She's going to talk to us about racial health disparities in military health system. You all have her bio in the emails that I sent you, but I will go ahead and introduce Dr. Colmos. Dr. Colmos is currently the director for the Center for Health Services Research and doctoral program in preventive medicine and biostatistics. She has been a user since July of 2015. And she teaches USAS, but also at the National Defense University. Prior to coming to USAS, she was special assistant to the assistant commandant of the Marine Corps with impressive over almost 200 publications and multimedia products. Dr. Colmos is kind of expert in leading complex tasks and program development, capacity building across spectrum of health systems building blocks. Prior to her domestic and defense healthcare work, she lived in several countries and really started in public health in leading health and family planning systems program in Dhaka, Bangladesh. And her research areas of interest include health equity, value-based care, women's health, systematic review, and health and national security. She's currently the National Secretary for Gold Star Wives of America and Deputy Chair for the Cochrane Library Oversight Committee. And she was previously an Army Air Defense Artillery Officer and a widow of Colonel Randall Moose Colmos and mother of Captain Robert Michael and Second Lieutenant David Colmos. So with that, I will invite Dr. Colmos over. She is willing to take questions during the presentation, so feel free to interrupt to ask questions. For those who are virtual, I'll monitor the chat and ask your questions. We'll also have time at the end for Q&A. Thank you.
Thank you so much. All right, so you guys know I'm going to start my timer for 40 minutes to make sure I don't go over and we have time to talk. I do this when I teach, actually, because I think it's a best practice. This talk, it's not that I'm lazy, it's that this is actually the exact same talk that I gave to the Defense Health Board on this very topic. And it ended up commissioning, look at this, I'm like two-fisting here, with the remote in one hand and the mic in the other. I feel like we should sing karaoke. When I talk about the military health system, I want you all to know that I didn't fall off the potato truck and land a great full, hard money job at USU. Some of you have had some histology and cytology, but the miracle of miracles is that the blood cells in this body are Army green. And they're marching in formation singing the Army song right now. So you can look at that on the lab slide and tell me if that's healthy or unhealthy. But it's, so we're all Army sort of all day at the House of Moose. I did have a lovely career that I enjoyed very much in global health. When I was widowed, the boys and I moved back. And while we're looking for perfectly respectable global health jobs in DC, I ended up instead becoming the assistant commandant, public health advisor for a few years, where I used to go to meetings and say, you don't do enough health services research, right? I used to stand up and I'd be like, you can't say that. You're not doing right by Marines and their families because you don't do enough of this thing that I do. So I joined the university and stood up the Center for Health Services Research, which sounds like it was a straight line, but there was a lot going on there. So what we're going to talk about today is something that actually is very important, not just to the military health system, because you'll discover in my talk that we actually do some amazing things that there's no equivalent for in the rest of US healthcare. So whereas we're on a journey and maybe have miles to go, we are so far ahead of the road. We are an example. The work that you all deliver, the care that you all deliver to our patients in the MHS, we are head and shoulders above other organizations in the country. So there's my disclaimer. I am the person who is most likely, I'm going to flip this around so I don't have to keep looking over my shoulder while talking to you. Again, you have to have an agenda if you're giving a talk. This is what we're going to do. And this is the talk I gave to the Defense Health Board exactly. So you're getting not just an overview of the paper that the team and I did, you're also getting sort of a background on disparities as well as what they whole enterprise, what the DoD should do next for in the area of disparities, and I'll be able to update you with those future directions. I'm out of range. So I'm not going to talk about the center. You guys can look us up. We have a website, but it's, you know, if you run a center, you do have to advertise it, right? To the people that fund you, like the Defense Health Board. So the big publication that they invited me in to talk about was this disparities. It was a framework synthesis of all these individual papers that we'd published looking at disparities. We didn't go into this. My background is, I did my PhD. I'm a PhD in public health, and my dissertation looked at, goodness, breast conserving surgery and radiotherapy, and looking for black-white disparities in the state of Florida in 2001. So despite the fact that I went on for like a lovely global health career, I started in disparities. This is like my mother tongue, right? Is to study this. When I got to USU, no one was really looking at disparities. We had a series of papers that came out in one of my projects, and I realized that when we did those racial analyses that you do if you do biostats and epidemiology, we weren't seeing things that I was expecting to see. So then the team moved in the direction of really purposefully going about studying racial differences in access and outcomes and processes of care. And when I went, I think since COVID, people no longer have to push the I believe button, that there's differences in how people experience care or wellness based on race. But I assure you that I once sat in somebody important's office in the E-ring of the Pentagon, and he flipped through the list of things I was working on, and he said, "Tracy, you're spending a lot of time looking at racial differences, and I don't think this is very important." He's like, "I'm not sure that this is the health services research that we're funding you to do. You know, it seems that there are other more important things." And I looked at him, and he's still around. And I was like, "Sir, the next time you're on the Hill testifying, I'd be holding this up and I'd be saying, the military health system is an example to the nation, and that this is the one thing that we do right. So before you dork us up and pull our funding, understand that this thing we do is Disneyland compared to everywhere else in this country." And he's like, "No, that's not it." So he never says it anymore, because now they go crazy, like in my inbox, with what's going on with access to prenatal care based on race and birth outcomes based on race. But we really went through a period of discouragement on this issue. So I feel like my ability as a professional, sometimes you read the tea leaves, I feel like my tea leaf reading ability really played out well for the military health system here. But you guys are the ones that are actually out there doing all the great work. So what are disparities, and what are they like in the rest of the US? They are the little bits at the edge of care when you already adjust for things like insurance-based access. It's what's left that's unjust, unequal, and unfair. That's left. It's minority patients consistently experience care of lower quality differently and with lower health outcomes or poorer health outcomes than majority group white populations in this country. Universal insurance, like the insurance that's offered through TRICARE or through the military health system, where there's no deductible, no or low copayment for most people, and no premiums. Everybody has access just because they're in the system, right? This is universal coverage. This is not the norm in the United States, whereas it is the norm in most other high-income countries. You don't have large populations who are uninsured. So universal coverage like we have is often proposed as a solution to our racial disparity problem in the nation. That if we could just get everybody into health insurance, all the problems would go away. So looking at the MHS is one way of testing this philosophy of looking at what if you gave everybody the same health insurance, right? All right. So the project that we did all the papers on in our systematic review was called the Comparative Effectiveness and Provider-Induced Demand Collaboration. We work along 5 or 6 core areas. And the whole goal of the project initially was just to see, could you do health services research using the military health system data repository, which I think is on the next slide. But it was really a test of, could you do this research in this big electronic health record? The answer is yes. And the answer is yes to, I think now we're up to like 112 publications. And so for this particular paper, we reviewed the 104 published manuscripts, and we identified that 28 of them included disparities related results. So we had 28 different products to talk about. So when we talk about what the military health system data repository is, I'm not going to assume that you all know. It's the electronic health record of the military health system, right? So it includes both the care that you all deliver in the direct care system of military treatment facilities, but it also includes the claims data for what we pay for when we send our patients out to the private sector for care. So we can see a lot of things in this system. We see laboratory data, we see prescriptions that are ordered, prescriptions that are filled, prescriptions that are refilled. We see diagnoses, and it serves 9.6 million beneficiaries. So this is a massive data set. And the other thing we can do is we can build families in this data set, right? So I have a monster new project looking at fetal alcohol syndrome disorder that I think some of you are my partners on. And the beauty of our data is we can look at the behaviors and diagnoses of alcohol use and alcohol use disorder in women before they're even thinking about becoming parents. And then we can follow them through a pregnancy. And then we can follow the health of that baby from 0 to 5, 7 years. No one else in the country can do this. And do you know why? It's because people change health insurance companies, and hence they get different data because they're following typically the least expensive insurer, right? If you're out there and you're a civilian, I don't know, does anybody have civilian health care in here? How much do you pay a month, my friend? What's your deductible? What's your premium? What's your co-payment? You don't know? Okay, all right, that's fair. So she doesn't know. So there you go. So people pay like thousands of dollars a month on health insurance, and co-payments might be like $90 a month, $90 a hit. But every time you go to see the doctor, your insurance kicks in, but you're still having to write a check for $90, right? Or I guess these days you would like swipe your card, because nobody's writing checks anymore. So we know a lot about these people from our 9.6 million Americans. So to be included in this study, the papers done by the EPIC project had to purposefully address racial disparities within as a primary or secondary outcome. We had to go in looking for a difference based on race. We didn't include studies that only looked at race in your table 1, your demographic table, so that's no good. So we did data extraction along a number of different elements. And I know that when I talk about methods are kind of boring, but I like them because this is the work that I do. So these are the things we abstracted data for. So we started with 77 manuscripts. We ended with 32 manuscripts, 9 from surgery, 7 from trauma, 5 from opioid use. There's a little overlapping here, some from women's health and cancer screenings. And so these are the things that we learned. So these are places where in the rest of the country, you would expect there to be a racial disparity in the outcome. And so we were able, for studies that did it, we can look at where care, so the green check mark is where there is no disparity. So it's where we would expect a disparity based on the literature, but we didn't find one in the military health system. And actually the surgery tranche of papers is pretty good compared to the others. We did really, we'll get to the end and there'll be like more red X's instead of green check marks. But you can see here, if we look at duration of stay after CABG surgery for men, it's the direct care system outperformed or was more equitable than we expect in the US healthcare system. But when we send our patients out to private sector care, the disparity remained. That's what the red X means in that case. Whereas for post-CABG surgery care, they were both equal. For trauma care, they were both equal with no disparity, right? And where we would really be expecting one if these were patients anywhere else in the United States. So it's a variety of surgeries that we did. So here we get to where for women's health, where things are a little more complex. So things like laparoscopic treatment of ectopic pregnancy. In the direct care system, we're delivering that care in a way that's just and quite equal. Whereas in the private sector, when we send our patients out, we see where African-American women are not having access to laparoscopic surgery for ectopic pregnancy at rates that are equal to that of white majority group women. Mental health diagnosis during pregnancy, we do see a greater disparity there, both in the private and direct care system. We do great for cancer screenings, right? If cancer screening is the pathway to early diagnosis and survival, then we're killing it here, actually. And one of the places we do really well, and you guys are family medicine, so maybe you're making these referrals, is Black men and women have more colonoscopies. They're more likely to be cared for a screening than any other race, actually. So we're outperforming. And then the cervical cancer was the same in the direct care system among active duty service women. Black women are more likely to be compliant with the guidelines for cervical cancer screening. And I can't tell you why that is. I can just tell you that it is, right? So it's when you're looking at the health record, you don't know why, you only know the result. We looked at our kids because, you know, we've got almost 2 million kids, and whereas you can say the active duty population are screened, right? Everybody's got at least a high school diploma. If they're an officer, they've got a college degree. When we talk about our pediatric patients, they come to us as God made them or as they were born. So we can see where things aren't as just as we would like them to be, that we're better for osteomyelitis and mental health diagnosis in direct care, but you can see where we still have disparities in other areas of care. For opioid practices, there were 5 papers here, and we have a very lengthy body of work that we've built on opioids, some of which looks at disparities and some doesn't. We found that Black patients were more likely to discontinue opioids compared to white patients. We found that Black patients were less likely to receive an opioid after trauma or surgery. And you might think that's good, but what it might mean is that we have Black patients who are in pain and their pain isn't being addressed. So it's an area that while there isn't a disparity, it's not necessarily a great way to not have a disparity. We would like things to be equal rather than unequal like this. And I can't tell you if that's because the Black patients experiencing these conditions self-selected out of opioids, or if it was providers didn't offer it to Black patients, right? But so that's a different study. And that's probably work that's worth doing, to be honest. There's some additional work that we did. We looked at the polytrauma clinical triad, which has a misspelling in it. So we found that Black and Asian Pacific Islander patients were less likely to be diagnosed with the polytrauma clinical triad. We found that white patients were more likely to be diagnosed with low back pain as we go through this. So the outcomes were really kind of mixed for many things. I'm not going to read these things like diabetes readmissions, where we had Black, white, racial equity in terms of use of care, but we saw where Native Americans were more likely to experience a readmission. So in terms of discussion, what is notable is that we were able to ameliorate a lot of disparities that are quite common on the outside. So when we do science, right, the journal of negative results, not finding a disparity doesn't seem like an exciting result, does it? Like, oh, we went out there to look at something and everything's great. Well, that doesn't get you into JAMA or the Lancet if things are great. But in this case, I mean, we've published in high impact journals articles that start with no disparity found, because these are differences that we've come to expect in the United States, unfortunately. So, it might be universal coverage. We suspect some element of this is universal coverage. Everybody in the system is covered. They're covered all the time with no co-payments and no deductibles and no premiums. Some disparities exist in the private sector, which implies that there's also something that goes on with our uniformed providers or our contractor GS providers who work in the system, who behave in ways that are different than their civilian colleagues work in a mile off base. That when we encounter patients, and it could be, I have colleagues at Brigham and Women's Hospital who will say to me, oh, it's because the color of the uniform is more important than the color of the skin. And I'm like, you can say that. I was like, but you have to prove it before we start putting that in articles. Because I don't know that that's true, but there's definitely something going on inside the direct care system. There's certainly more research is needed. I wanted to move through this. This is a summary chart, but some more on disparities is, because the Defense Health Board were not experts on disparities, I wanted them to understand where we come from as a nation. The seminal work on disparities in the US is called Unequal Treatment, and it came out from the Institute of Medicine in 2001. So whereas we may have known we had these differences in how care was received and health outcomes and just general wellness, we didn't really give it a name at the national level till 2001. If you talk about social determinants of health, that language wasn't really qualified till Sir Michael Mormont's report with WHO on social determinants of health in 2006. So if you're 24 or younger, that might seem like a long time ago, but in terms of how we study health and healthcare, it's really, these are still new and rather emerging concepts. So it's, the disparity is the bit that's left over once you've accounted for things like access to care, distance to care, cost of care, and economic status. When we think about what we need to know or do around disparities in the military health system, there's no knowns. This is the Johari window. If you ever take an organizational behavioral class, you'll become familiar with this. There's things that we know that are known. There's things that we know we don't know. And then there's well, of course, then there's that box of things that we don't know because they're unknown to begin with. So we don't need to talk about those at all. So when we think about disparities, we know what we know, but then we also know that there's things we should be doing, right? When I finished my talk with the Defense Health Board, they were like, well, why didn't you look for disparities in the top 10 diagnosis codes in the military health system? And I was like, because I didn't know that was unknown and that I should prioritize doing it. So of course we scurried away and are working on that now. But it's in the universe of things you can do. So for us going forward, it's, there's other places and other people who are generating data on disparities as well. So the Murtha Cancer Center, who actually does a great deal of disparities research using the clinical registry for cancer, they looked at things like survival, different survival measures where there's an expected disparity that we don't find, so it gets the green check, but then where the disparity remains, like in the rest of America, it still gets the red check. CHAMP has looked at which is one of the other centers, has looked at disparities in sickle cell screening efforts. And we can debate whether a disease that actually exists predominantly in one population can even open itself up as something to be discussed as a disparity. But this is how they've addressed disparities. And I'd welcome your opinions on that, because I'm like, that's not really disparity science. But it becomes disparities if we don't allow Black men and women to join the service because of factors related to this. That's where the disparity is. So it's not necessarily in the care. Those are things that take place outside of the health system. So in terms of active duty service men and women, what we need to remember is that looking at our health system and our population is important because we are overrepresented for minority groups compared to the rest of the country. So it becomes a great learning environment, again, where the Department of Defense can give leadership to communities and health systems and programs across the country because we're overrepresented for these things. There are a number of diversity, equity, and inclusion efforts going on across the military health system. So for example, the clinical communities have working groups that focus on looking at disparities issues. So the Women, Infant, Children group is really concerned with birth outcomes and pregnancy experiences of Black women. And I can tell you, spoiler alert, because we've not published this yet, but we've talked about it a great deal. If you look at active duty service women, and that's socioeconomically, that's a pretty flat population. You know, everybody's got at least a high school diploma. Everybody's fit mentally and physically enough to serve on active duty in the military. Everybody has universal health coverage to support her pregnancy. We still see more low birth weight babies in African American service women. And it should be the same, right? If everybody has the same care and the population's actually very much the same, those differences shouldn't exist. So one of my obsessions is, what do we look at next? And it's probably like looking at epigenetics or the impact of stress or adverse childhood events to try to go this last mile to make sure that active duty service women who are Black are able to have a fabulous pregnancy and a fabulous outcome of that pregnancy with a healthy baby who's ready to, you know, come home and join the family as soon as possible without any extra concerns. Each of the different services also now has offices for diversity, equity, and inclusion in their manpower personnel for medicine, right? It's how do we create a workforce? You may or may not be aware that outcomes are improved in many areas where there's patient-provider racial concordance. So I'm a Puerto Rican woman. If I needed mental health services, my mental health services would be more successful. My outcome would be better if my provider was Puerto Rican like I am. And we see this a lot with Black mental health outcomes in the country. We see it with Black pediatric outcomes in the country, with infant mortality. So the race of the provider matters. And right now, we don't have the ability in our data set to study this. We're working on it. In a couple of different ways, we're working on it, but we don't have it. But in the services can tell us how many Black women psychiatrists we have, how many Black women psychologists we have working in the system to try to help us edge towards these goals that will help to further alleviate and go that last mile on racial disparities. So we worked a lot with the Air Force and their medical services. They came forward with data for us, and they were able to provide us with the racial breakdown by physicians and physicians' assistants. And the thing, well, of course, 15% declined to respond, but in previous slides, I showed that 17% of active duty service members are Black. If we look at who our doctors are, it's 4%, right? For the Air Force, it's only 4%. So that hampers our ability to improve health outcomes by having concordant provider-patient race in encounters. So these things matter. The same with PAs, it's similar. Here we go. And then nurses again, and med techs, we get a little more representative there. So, and then there's other efforts that have gone on to try to ameliorate racial disparities and go this last mile. One is at USU, we have the Enlisted to Medical Degree program, which takes people who are, do you guys know this program? Okay, then I won't talk about it. We've added a thread on equity and health equity to the med school curriculum to help everybody to help you all not become the senior leader in the future who has someone say, look at our good, our racial disparities outcomes are fabulous, and you not be that leader who's like, nobody cares about that. That's not a good use of your time. So you guys will be better going out into the world. And I think sometimes it's like that first step in Alcoholics Anonymous, the first step is admitting you have a problem. Well, in this case, you all will know that there's a problem and that it's something that can and should be addressed. And we also do a lot of summer programs at USU to sort of sway young men and women to come into the sciences and pursue a career in the sciences. So what should the military health system do next? And so this is the part that the Defense Health Agency was taking notes, and the Defense Health Board they've ordered these things that I'm about to talk about. Like, so we'll know these answers soon. So we felt that the immediate task was to do a comprehensive systematic review of the racial disparities literature, not just the convenience reviews of studies from my one project. So that's taking place right now. Further, we think that there should be an evidence map or a gap map about where we know disparities exist in the rest of the country, and then see what we know about what's going on in the DoD, in the MHS, and then fix that. That there should be an inventory and synthesis of DEI efforts for health, the care, the outcomes, the workforce, and then of course for women's health, what should we do besides just look at this data from the military health system data repository. And then these are just breakdowns of what it is I think we should do. And then, so there's more work coming soon. I don't want to give you guys too much of a spoiler alert, but the disparities in maternal outcomes for active duty service women, I feel like I talked about that. There is a disparity, disparities in contraception utilization for active duty service women. We find that Black active duty service women are less likely to use LARC, a long-acting contraceptive method, less likely to use sterilization. Telehealth during COVID-19, and we applied the social determinants of health. And whereas the rest of the nation found that telehealth was unequally distributed, spoiler alert, there were no differences based on gender, race, or age in our population. That when we rolled this out during COVID, we rolled it out in a way that was just and equitable. So good job, providers. Future needs, impact of provider race on outcomes in the MHS. We're definitely working on that right now. You guys can high five yourselves all the way to the bank. Good job. So we're looking at the provider race outcomes. We're looking more at service women's health beyond the MDR and universal access. And then of course, because I study value-based care, I'm going to put my own thing in here that we need to do more value-based care through a social determinants or race-based lens. There's more to do. This is how you can contact me for like ever. It's my email address, but don't ever call me at that number because I'm never at my desk. So it's just email me and my cell phone number will pop up. You can visit the center's website, and we have a Twitter page now that we're like really proud of. There you go. And that is that. Do you guys have any questions for me? I feel like I sped through that in record time, but I think it's because I've been giving this talk so I hope that it sounded fresh instead of like, boy, I give this talk once a week. So what questions do you have? Thank you, because you can't have sat here and not been like having questions. So that makes me feel better. Thanks.
So my question is for graduate medical education opportunities for residents with some of these research efforts. I think as a national business, we have what would be the best path?
No, that's great. So I don't call the students minions because that's not polite. We call them research extenders, because what I would say to all of you is I am not a clinician, and my team, and this is why I work with Colonel Nguyen and Colonel Ray. I'm not going to call you by your, I'm not going to call you Gigi in front of the students. Colonel Gigi, just in the way that I'm like Dr. Tracy, right? Although Colonel Gigi has a nice ring to it, but I think it's not the spirit of the thing. So I don't know all the questions, right? Because I'm not a clinician. I don't know what you all are seeing out there in terms of patient care. So I often look to providers to bring their clinical expertise to my team, right? That you say to me, hey, I think there's something going on with diastasis recti in active duty service women, that there might be something going on there with them. And then we can work together to design a study around DR, right? And then it's the same thing with, we looked at alopecia in active duty service women. Were you on that with us? Okay. And it was around the time that the services were discussing this amongst themselves. And what we found was we found a racial disparity. It's not in the paper, where, again, not a surprise to anyone, but Well, the Black active duty service women were more likely to experience this. So there was something unjust there was a health outcome that was unjust based on a policy, right? So that's something that policy can be changed. And so you're welcome for the ponytails, for the ponytail wearers in this room. Free the bun. So yeah, so that's how we, and the other thing I would say is that I'm under, and I didn't see who joined us, if it's any more than like Paul and Jeff, but I'm under a lot of pressure from Dean Elster to work with undergraduate medical students. My frustration is you guys come in and you can't quite do any statistics or epi, but we're already working with two delightful, thank you for sending them my way, two delightful undergraduate medical students on, this will resonate with you guys, but I have to say it the right way to make it more sciencey. The association between BMI, meeting or not meeting, or being close to meeting body composition standards by service, and then the association with disordered eating, right? Because we know people do crazy stuff to try to make height weight, depending on what height weight is in their service. You know, and particularly like if you're in the Army and you weigh 110 pounds, are you ever lifting up a hex bar heavy enough to get 100 points, right? We may have just incentivized people to be bigger, and women to be bigger than men, to be bigger than they ever were before. So in the Marine Corps, when they introduced the pull-up, right? The ladies, the women who are Marines, came to us after they came to me, because I was like the lady working in headquarters Marine Corps, and they're like, listen, Dr. K, I'm having to have my shirts let out because now I can do 10 pull-ups. You know, I can't run 3 miles in 21 minutes, you know, do a plank for an hour and then do 10 pull-ups and be like a stick. And so women were awarded the body composition standard change, awarding every height woman an extra 5 pounds. I'm not sure that 5 pounds was a scientific solution, but they did. They changed the standard to accommodate the wellness or readiness requirement for the warfighter. And so we think that so what we'll figure out is, you know, if with these med students is, if there is some sort of association with being over, under, or close, or if sort of everybody is equally having disordered eating diagnoses, or maybe nobody has it in their medical record. We will learn this together. So, you know, and going on the I'm going to eat tomatoes for a week diet is not disordered eating. It's totally normal, not going in your medical record, not talking about it with a healthcare professional. So I worked, and so that you guys will know, if you've not, were any of you Marines like in a previous life? Because I know sometimes there's med students who were Marines. Were you a Marine in your previous life? Because you could be. You could have flown jets, right? We never know before you went to med school. Exactly. When you're with Marines, Marines always have a snack. And it's usually like carrots, grapes, or hummus or something. But in my own office, we would do like the 8-day diet where there was like, today we're only going to eat white meat chicken with no bones, and tomorrow we're going to eat tomatoes all days. I mean, it's like institutionalized. So I don't know that people would recognize that being built like a teenager into your 60s might be a representative of something that deserves discussion with a healthcare professional. So either mental health or otherwise. So, and I know this is being recorded. I'm so sorry, God. I'm so sorry. So glad I have tenure. What else, you guys? Yes, Alan. You know, I'm not sure that that's a model that works for us as a community that moves, right? We're a community of movers. So for my Black active duty service women who demonstrated, and Jeff, I hope you're listening, they demonstrated an unexpectedly high rate of self-reported alcohol use and diagnosed alcohol use disorder, both before the pandemic, during the pandemic, with or without children, right? The mommy wine culture, mommy, I'm the reason mommy drinks on the onesie. Like we have a soft core alcoholism encouraging thing going on in our culture these days. But in the rest of the nation, Black women don't have higher rates of AU and AUD than white women. So we had this eureka moment. And ever since then, I'm like, how are we going to get the right care for our active duty service women who are Black? Because one, there's never going to be enough providers. Look at where we're starting from, right? It's not, and the shortage isn't just ours in the MHS. It's a national shortage of, well, for mental health, there just aren't enough mental health providers, but there aren't enough Black mental health providers, right? Of any caliber, right? It's not that you have to have the PhD or be the MD who's a psychiatrist. It's even at the level of social worker and LMFT, right? There just aren't enough. And it's a problem that's much bigger than the MHS. But in our system in particular, if Black women are having a problem and they're at Keesler Air Force Base, I don't know that I'm going to have a Black provider there to meet their needs. And so this issue of racial concordance in provider and patient, it's a tough one. And most of the communities that are working on that are people that don't move all the time, right? It's people tend to live in an area and stay there. So you can build your health system to support your population. And with us, we're going to have to be clever. But the good news is we know that for telehealth, we know we can be just and fair with telehealth. And maybe in the way that when I go to the doctor, which is never, because I'm Puerto Rican, right? I say, sienta bien, I am fine, thank you very much. And you guys will be wheeling me out of here dead, and I'll be like, I'm fine, it's only a flesh wound. But it's when I go to my provider, and I'm a woman, right? And I need to, they're like, oh, you should get a pap smear because you're Jew. And I have the option of going to be seen by a woman, which is an example of patient-provider concordance. So we have the track record for that. So it must be like 12:41. So we've got a little more time. It's 12:45. So but again, I don't know how we set up our services to not seem, to be just, fair, and equitable, where if we have a Black Air Force sergeant who's having mental health issues or wants to talk to someone, that she can say, listen, I want to talk to a Black woman. And we're not set up right now to enable that concordance or that connection. But I don't know what health system would be the thing. So, yes, ma'am. Yeah. But I bet you get it all the time, where you've got, exactly, where patients are like, are you the nurse? Right, it's the opposite of that. But well, because it's impolite, right? It's impolite when it's said to us, you know, and when people say it to us as providers, are you the doctor? Boy, you know, you're like a lady doctor or whatever. So it's learning to have a conversation or setting up mechanisms that are normally considered impolite. It's an impolite conversation to have, but we have to, if this is something that saves lives, we have to figure out, one, we need to figure, maybe it's not us, but maybe we look at the literature more broadly and we figure out how much of a difference does it make? Although, you know what, if we're talking about infant mortality, every baby's life matters. You know, we want, every baby has to make it, right? But so we need to figure out where to put our efforts. Yeah, it's hard. It's a hard thing, right? Anything from anybody online? I want you to feel included. No, nothing, getting the no sign. All right, I know the students are like drifting out. Don't you have class? Or are you not a student? Okay, okay. All right. Because the students are all in tracksuits. Does that mean they're going to go poke each other in their next class? All right. That's why I did not go to med school. I don't want to poke anyone. I want everybody to have their clothes on. All right. Anything else, you guys? It's a tough nut.
But one debate I remember having at a previous job was, right, for example, in front of like the Jesus family medicine department, there's like a wall of photos, right? So I remember thinking, I wonder if someone wanted to find someone like them, how they would even know, right? So point being, at other random Air Force NTS clinic, people would know what any of our providers look like, and that's less of a demand. I mean, an attempt to get our faces out there. Because then in the tracker system, change go in and sort of self-select and change minutes or, have that recur to do that. But I don't always think we provide them with the information to make those decisions.
I think that's, so for those of you online, Colonel Gigi just pointed out that, that TRICARE can do better with getting the providers out there so that patients making a choice maybe for their primary care provider, maybe it's a picture next to the name of each provider, and I can be like, oh, that's a woman, that's who I would be more comfortable going to a woman. Or conversely, men might be like, I really don't want to see a lady. I'm more comfortable going to a man. Yes, ma'am. Right. Oh. No, that sounds.
And then they're like disappointed.
Oh, I didn't even think about that. That's really funny. So you're like. That's really funny. So for those of you online, Dr. Colonel Nguyen just pointed out that Vietnamese patients seek her out and are disappointed by her. But really they should be delighted because you're a fabulous provider. But it's true. The discussion in the room has been that TRICARE can do better. And it is true. Like if you're going to a civilian practice, like for your mental health care, it'll describe the doctor, and the doctor might say, I specialize in low-income settings, or I specialize in LGBTQ plus patients. There's space for that. And I don't know why we don't have that. So that's a really good point. Yes, ma'am.
There is a question online. You comment about better behavioral outcomes related to racial concordance and central understanding. How do we understand underlying causes related to race versus structural?
So there's wonderful systematic reviews about that. Oh, so the question was, how do you, is it that it is more than race? It's also cultural understanding, with race or gender often being like the gateway to cultural understanding for most people. So when you look at, there's wonderful systematic reviews, particularly for mental health, because I have a doctoral student. As you guys know, Jessica Jackson, this is literally what she's doing her dissertation on. So there's a whole literature on that, like in several systematic reviews of various elements of mental health outcomes based on patient-provider concordance. And in that framework, race, gender, cultural understanding are parts of that. And so I don't actually know all the answers yet because I'm waiting for her to finish her research, which won't be done fast enough. All right, what else? And thank you for online for that question. And we can be done. So, and if anyone has trained or worked in Ukraine over the last 4 or 5 years, that's the meeting that I'm at, and I could use insight from you guys. All right, so I'm gonna go back to my trauma system evaluation meeting. And thank you all. Thank you.
Just want to say a quick thanks too, and I don't know, have you ever gotten a coin from us?
No, but you guys are like my second favorite department.
Yes, from the Department of Family Medicine. Thank you for speaking us today and all the time you put into letting us join on projects and carrying us along.
Didn't know I was Army.
Honorary member
No,
now.
well, I love you guys. And I'm waiting to be on research committee.
Thank you.
Thank you, guys.